So we've got Luca with me.
Hi.
And Lucien behind me somewhere. And Andrea, our vascular surgeon who did the cut down. And Thomas is the anesthetist. And there's a huge team otherwise as well, whose names I cannot remember. So what we'll do is we'll start off with Francesca, who's going to present the case to you.
I don't have them. Sorry for the delay. Here we go.
She's disappeared now.
Here I am.
She had to do makeup first.
So the patient is a male, 36 years old, 86 kilos. He had a native aortic coarctation and a small muscular VSD. He presented with systemic arterial hypertension. On physical examination, you see the blood pressure is 150/90. This is the ECG and the chest X-ray. So on echo, there's a small VSD with mild left-to-right shunt with a peak velocity over 4 meters per second, and you can see an hypertrophic left ventricle with normal size and function. So also on echo has been detected a bicuspid aortic valve that is normal functioning, and there's a diastolic runoff in the abdominal aorta. We did a CT, so the CT confirmed the severe aortic coarctation, the dilation of the left subclavian artery and of the mammary and on all the intercostal arteries. This has been confirmed as well on the cardiac MRI. So the aortic coarctation, you can see clearly here, is about 3 centimeters distal to the left subclavian artery. The minimum diameter has been measured in the black blood imaging and is about 5 millimeters. The proximal aorta is 18 and the distal is 21 millimeter. On the angiography, you can appreciate the multiple collaterals coming from the epiaortic and intercostal arteries. So here, our bioengineering processes the imaging. You can see on the left the 4D flow acquired on MRI. You can see there's particular shape on the ascending aorta that is probably due to the bicuspid aortic valve. And then there's actually not much of a flow through the narrowing part of the thoracic aorta. And indeed, in that part, the velocity is very, very low because of all the collateral circles. On the right side, you can appreciate the simulation of the stent implantation. The stent is, the coarctation is very distal from the subclavian artery, and the stent is, in this simulation, is opening very well the aorta. Thank you. We can carry on with the case.
Thank you very much, Francesca. So the first thing I can tell you is Luca's doing all the hard work, and he's measured the gradient across the coarctation, and it's around 40 millimeters of mercury pressure difference between the ascending aorta and the descending and femoral arteries. So the next thing he's done is a 3D rotational angiogram, which, tell me if you can see the pictures or not. Okay, so, and there is the 3D reconstruction bottom left. And so any questions, thoughts, suggestions from your side? I'm trying to remember who you've got with you. I think Carlos or not? And
we have Axel, Carlos. Carlos asked about the measurements in Gerlin. Yes,
hi, Carlos. So the measurements, we'll come to those in a minute from angiograms. Obviously, the CT and MRI measurements you've seen from Francesca, they were around 18 millimeters, just distal to the left subclavian artery, 21 millimeters post-stenotic dilatation part, and about 4 or 5 millimeters the narrowest part. Yep. Any other thoughts on the anatomy here and what to do?
Yep. And go all the way down below the coarctation. This would give you a longer stent or just cover the coarctation itself.
Yep, very good. So very good point. My thought was also along what you were just suggesting, because the distal aorta isthmus region is hypoplastic. So I was thinking of putting a longish stent to cover that part as well as the coarctation. So the next thing we did was regular angiograms. If you could show the next picture. There we are with the pigtail just flicked into the left subclavian artery, but that's highlighting the coarctation again. Next one. That's really just a pigtail pulled back with the holes across the coarctation. And you can see, certainly on that projection, a very tight aortic coarctation, and it really shows the anatomy quite well. Any suggestions of the types of stent, bare, covered, what diameter to take them up to, and so on, from your side, Carlos or Amy?
Well, yeah, I think this is a case that we should use definitely cover stent. I would go with the CP stent, 8 Zeke, and I'm not sure, maybe 39 on 45. It depends on the length and your plan.
So we've got measurements for you, Carlos.
To me, that it's the isthmus is not that bad. Yeah, there you go. Beautiful.
So the length that you mentioned, from the left subclavian artery to the coarct, it's about 27 millimeters, and then well, I've just picked a random measurement below that, which is X6, so another 27. So the whole very long segment would add up to 54, but obviously we won't have a stent of that length. But my focus would be to do the top bit and the coarctation, and then have a bit of the stent hanging down. Does that seem reasonable?
Perfect.
Yeah, that sounds good.
Yeah. So we are not going to use the CP stent. We're going to use the Bentley B graft, which I happen to have here. Now, this is pre-mounted, so obviously I don't have to waste too much time mounting it. However, even when it's pre-mounted, it has a tendency to slip, so you still have to crimp it down. So we've done the crimping down already. Oh, well, I haven't. Lucienne has, because she's stronger than me. And so now, with Lucienne's strength, you can't see it moving at all, yeah? And there are two markers there on the balloon, so the stent is nicely in position.
So is this covered on both sides or just the outside?
Sorry?
Is this covered on the outside and the
Yeah.
inside of the
So-
stent? You talked about the covering.
So the stent is, the metal is cobalt chromium, and the covering is PTFE, and that's on the outside. It comes pre-mounted, so the one we've picked is an 18 millimeter diameter, 48 millimeter length. So I think that's the longest one they've got for the aorta. That's the stent. And then it's important to have this protection sheath when we introduce it. So the next angio we will show you is Luca has put a 14 French Mullins sheath in place. This stent requires a 14 French. The smaller diameter, around 16 or less, require a 12 French sheath, I think. This one, 18, 20, 22, all of those require a 14 French sheath. So the sheath is in Mullins sheath. Can you see that in position?
Yep. Yes.
Yes, we can.
Oh,
And
okay.
does the stent shorten?
Yes, so if we inflate this 18 millimeter to full 18, the 48 length shortens to around 41 millimeters. So there is some shortening there. The other thing that, although we use indeflator, the balloon does have some extra volume leeway, so you can overdilate. This balloon's burst pressure is around 5 or 6 bars, I think. But this 18 one can be overdilated subsequently to up to 30 millimeters. So there is that capability. Obviously, if you have to dilate to that diameter, then it will shorten quite a lot. So can I have a flush syringe?
Jack,
Yep.
this is Elkanon. I just want to make one point about
Yeah.
the stent.
Just,
Was that it's not relevant necessarily for this patient because they're an adult.
yeah.
So you're using a large delivery system. But if
Right, yeah.
There's a 1248.
Yeah.
And then you could do this and then post-dilate it.
Yeah.
So you can do quite large stenting with small slippery systems.
Yeah, correct, yeah. So now, Luca, if you put the sheath through. So Luca's just pushing the sheath in. That's it, and now advance that. Okay. Good.
Okay.
Oh, a lot of bleeding here,
Yeah.
isn't there? Oh. Okay, so let's show you the stent going up, the sheath. By the way, the shaft is 120 length, which is important, obviously, because the other shaft on these is around 80. So what you don't want to do is use a 75 length mullion sheath and then use the 80 length shaft, and then you won't come out of the
Storfuro?
end of the
Fai gli
sheath.
storfuri.
So we need to do check angio, just to...
Tu do un angio, riempri, fai un check prima, fai un test, tu do il test. Ok.
Okay, so
Tu do a proper angio.
there's the left subclavian.
Yeah.
So let's half expose, and then we'll do
Bit.
just 50%. So we're just pulling the sheath back,
Do a proper angio.
a little bit more exposure.
Ok.
About there, yeah.
Tu do an angio. Yeah. Go. Ready?
Okay, so that's half exposed, and the sheath is pretty much at the coarctation point. The landmarks are the two ribs there, and the coarctation is between the two ribs. In fact, exactly where the mullion sheath radiopaque tip is. So now we can expose the rest. Do you think, Carlos or Amy, are you happy with that positioning? Replay the last angio?
Yeah, I think that looks great.
Maybe just a tad up, like
Yeah, just to push.
Your upper leg looks
5 millimeters.
Yeah, just 2 or 3.
looks nice. The wire isn't
Come
really
back,
distorting it too much.
Right, stent up
Right on.
2 or 3 millimeters. Yeah. Yeah, that's it. And then if you keep the stent there and withdraw the sheath.
Yeah.
It's so tight, I wouldn't worry. Yeah, I wouldn't worry about pacing. Just a
Storfuro.
little push up,
Push up.
just a little. Yeah. Okay, so let's do one more angio, and then we'll inflate.
Possible to do an angio?
Yeah.
Yeah. Go.
Okay. So the stent is pretty much over. We can push up a little bit, just
Yeah.
about 2 or 3 millimeters. Just want to make sure the top end is. Yeah, that's it. So what do you think? I think we're reasonably happy with that positioning, aren't you?
That looks nice.
Yeah, Carlos?
Yes.
So Lucian? Yeah. So you do that. And I'll do this. So we're going to do the volume. Yeah, go ahead. Just go slowly. Yeah.
Fai lo storfuro.
So we're just inflating the balloon by hand first, very slowly. And then I'll do the indeflator after that. You can see how it shortens, can't you? So if you turn towards me, yeah. And then, in fact,
How
It-
much pressure does this balloon take?
well, it can go up to 6, but I'm now at 2, and it looks as if it's the lesion's given, hasn't it? So I'm going to just maintain it at...
Compliant lesion then.
Yeah, yeah. So I'll just go up to 4, just to make sure we're about there, yeah. Okay, so deflate.
Tour.
Nice if you could
Okay.
acquire do that on Cine when you deflate the balloon to appreciate the recoil. of the
Yeah, yeah. Are you fluoroing there?
Yeah.
Oh, okay, we probably...
This recoil, I'm not
Are
familiar.
you-
It does...
That's a bit of recoil.
The stent does recoil, so sometimes, and so that's an important point. So we just need to check an angio somewhere if
Yeah,
we can.
do a check now?
Yeah. So keep the balloon there. Just advance the sheath over
Yeah.
it at the moment, because we might need to reinflate. And the balloon sometimes gets winging, and it can be difficult to pull in. But Luca's doing a very good job there. Okay, so if you hold the sheath,
Yeah.
and I'll pull the balloon down.
Okay, first.
Contrast in syringe.
Yeah.
20.
20.
So just going to do a check angio before we pull the balloon out, and whether we need to redilate a bit more or not. An acquisition, if you could.
Perforo.
And then acquire, yeah?
Acquire, yes. When do you want?
Okay, go.
Good.
So what do you think of that at the moment? Do you think that looks reasonable?
Oh, it looks good. As opposed to the wall, I think it's fine.
Yeah. We'll do a proper angio in a minute, but I think the top end is nicely opposed to the distal aorta, and it matches the diameter. The bottom end, I'm not keen on flaring usually. Occasionally I flare if there's a huge discrepancy, but what do you think about flaring, Carlos or Amy?
Yeah, I agree. I bet there is no gradient there. And the size of the stent is about the same size of the arch, so
Yeah.
I don't think you have to overdilate, kind of, probably.
Okay, so let's take the...
Yeah, I don't dilate the distal end either.
Yeah. So let's take
If
the...
ever it's shown, it'd be helpful.
Okay, let's take the balloon out, and then we'll do a proper angio in 2 projections if we could.
Do you do 3D rotation?
Hmm?
If you want.
Oh, yeah,
Yeah,
if you
to
could.
3D rotation on geography, we do
Yeah.
this shit.
Yeah, or...
But sometimes I do check. I leave the wire and put the pigtail
Yeah.
in parallel to the wire so that, you can have the angio if you need to do something else,
Yeah.
which I don't think it's the case here. Then you could proceed without losing wire position.
Yeah. Okay, so let's
It
take...
does bleed, however,
Mm.
a little bit,
Yeah, so what we're going
especially
to...
with this blue hook sheet.
So pigtail. Yeah.
Pigtail?
So we're going to actually put a pigtail over the wire, and
No,
then Luca is keen on doing a 3D rotational, which is a good idea. The overlay helped quite a bit. I'm not always a fan of this, but that was helping quite a bit.
So while you do that, what are the plans for these patients in terms of imaging after a year like CT? And what I'm curious to hear, not only from you guys, but also from the audience, if someone could be in, is how to deal with these diseased aorta, because you have a very dilated ascending aorta. Would you guys keep this patient on beta blockers for lifetime, regardless of blood pressure measurements? So what would be the strategy in this regard to protect the aortic wall?
So this is a 36-year-old, I think. So generally, we would give antiplatelets for about 6 months in this age group and then stop. He is, I think he's on antihypertensive medication, and certainly beta blockers. If there are no contraindications, I maintain those. Then CT scan in about a year, and then after that, regular follow-up. What are the thoughts from your end?
Well, we usually do a CT after a year. Of course, we keep an eye on flow by echo. If there's diastolic invasion,
Lavata-
runoff, then
Lava la
of course,
seconda linea.
there is recortation, and we tend to place to keep these patients on beta blockers, regardless of the blood
Facciamo gli
pressure,
zeri, per
just
favore.
to protect the artery.
Yeah.
There's not much evidence. Maybe this is derived from Marfan patients, so that's what we do in practice.
Yeah. Okay. Shall we do the
The zero to do the
angio?
sheet in the descendant
Yeah,
aorta
that's fine.
and the pigtail in the ascendant aorta. Okay. To the see check the pressure.
Okay.
To do check at zero. Fatto.
We're just checking the pressures at the moment.
Ok. Togli la verde. No gradient across.
Yeah, so there's about less than 5 millimeters of mercury gradient between the pigtail and the sheath. So now if we do angiogram,
Yeah. To do come back the pigtail.
yeah,
to-
yeah, to just above.
Yeah. Test. Okay. You know proper angio? You agree? Ready? Go.
Yeah. Okay, so, all right, we didn't do 3D, but that, I'm happy with that. What do you think, Carlos and Amy?
Looks great. Looks great. And I think it's certainly reasonable to just do a 3D afterwards too and not do the 2D.
Hey guys, let's do a real angiogram, not a PC-gram. Come on.
Do a real
All right,
3D.
he wants a proper angiogram, Luca. Luca's sending the mafia people around to you, Carlos. Okay, so shall we do a 3D RA?
Yeah. Prepariamo per la 3D. Sì. Entrati. Togli qualche ingrandimento. Ok. Upper the table. Upper table.
Could you tell us what settings are you using for 3D
Okay.
rotation?
Okay, Luca.
I think people like to know that.
Luca,
That's
what settings are you using for the 3D RA?
what do you do a 3D card for
Yeah, so what settings in terms of, all right, contrast, how much?
yeah, how much? 55 contrast. Oh, 60A. 13 ml to second.
And
the two rotation about 5
strength of the contrast,
Yeah.
neat or diluted?
Diluted.
And what strength?
Yeah. Allora, 1001.
So it looks like 78 mils at 13 mils per second. So that's a 6-second acquisition. And
to the rapid,
some
okay. We go?
and we're doing pacing. Yeah.
Okay. Stacca la respirazione. Vai col peso.
Not into the aorta.
Pardon?
Have you ever tried injecting not into the aorta but into the ventricle? Allows
Togli.
this contrast to mix a little bit and then you have the aorta full and
Okay.
you can see everything even without pacing. And
Yeah.
usually we use undiluted contrast.
Okay, yeah. All right, so let's do a quick reconstruction and then the program can continue and we're done, I think. So what do you think? I mean, there's a 3D rotational angiogram being reconstructed, but the one that you're seeing, any thoughts on that so far? It looks all right to me.
Yes, it looks very nice. And this is a good way to see any aneurysms that you might not be able to see on a 2D angiogram.
Yeah.
So I like looking at the 2D spin, and I think the reconstruction will look good.
And
The
what?
comment was
Yeah.
considering injecting in the left ventricle
Yeah.
so you don't
I got it,
get
sir.
the negative contrast washout that
Yeah.
you have here.
Yeah, that's fair enough. There is a collateral that we can see just in case somebody says there's an aneurysm.
Oh, it's really nice. have your technicians doing the post-processing?
Yeah, they're doing it at the moment. Can you see that now or not? At the bottom left?
Yes, we can.
Yeah. All right. Any other?
Congratulations.
Thanks.
Excellent. Good job, guys.
Well done to the whole team. Thank you.
Thank you. See you.
Thank you, Andrea.